Right, good afternoon, everybody, and a very warm welcome to the Academy of Science of South Africa webinar on priorities for child and adolescent mental health services and research in South Africa. It's really a great pleasure to see so many people attending today to hear more about this really important issue. So my name is Crick Lund. I'm a professor of global mental health at King's College London. And I'm also an honorary professor in the Department of Psychiatry and Mental Health at the University of Cape Town, and I'm based here in Cape Town. We've got a really interesting panel today of people from a variety of different career stages, all with expertise in child and adolescent mental health, and we're really looking forward to hearing from them. Before we get going with their talks, I just wanted to say a few words of introduction. The first is to say a big thank you to the Academy of Science of South Africa for organizing this webinar. This webinar is the first of a series of webinars that the Academy of Science is going to be organizing, focusing on mental health in South Africa. And I think it's really huge credit to ASAF for giving greater scientific and also policy attention to this really important issue of mental health. So a big thank you, and especially to Dr. Kutso Palani, who's been very much involved in organizing this event. I also wanted to just say how important this whole issue of child and adolescent mental health is. We know, of course, that mental health is a neglected issue, but even within mental health, children and adolescents remain really neglected. And this is a huge missed opportunity because most of the South African population actually is comprised of children and adolescents. We have a very youthful population. And we also know that child and adolescent mental health is a huge predictor of mental health across the life course. And so if we are to adopt a public health approach to mental health, we need to intervene early, and we need to make sure that the right kinds of prevention, promotion, and treatment services are available for the mental health of children and adolescents. We know in South Africa that there's a huge burden of child and adolescent mental health problems and a huge unmet need for care, especially. And so it's really appropriate that this first webinar organized by the Academy of Science is focusing on children and adolescents. I'm going to begin by introducing our first speaker, who is Dr. Mokatimi Bukalo Babatunde. She has a Bachelor of Science degree in psychology, an honors degree in psychology, a master's in health promotion, and has recently completed her doctorate in public health from the University of KwaZulu-Natal. She's currently a postdoctoral fellow at the Center for Rural Health at the College of Health Sciences, University of KwaZulu-Natal. So I'm not going to go through her whole biography in detail, but Dr. Babatunde, I'm going to hand over to you to please give us your talk. And also just to say my job as chair is to keep an eye on the time. So I'll give you a 5-minute warning just before your time runs up. And over to you. Thank you very much. Welcome.
Thank you so much, Professor Crick Lund. And thank you to ASA for the opportunity to be part of this webinar. I'll just share my screen quickly. So this afternoon, I'll be presenting findings from a study that we conducted at the Center for Rural Health. Which was focused on identifying multi-level and multi-sectoral strategies for improving child and adolescent mental health services in a district within the KwaZulu-Natal province. I'd just like to acknowledge my supervisors, Dr. Andrew van Ransberg, Professor Havin Banner, and Professor Henry Peterson. I would provide a brief description of the methodology that we used. We used the multi-method approach. So we started by conducting a scoping review of access to child and adolescent mental health services in low and middle income countries. And then we went on to do a situation analysis. And then we conducted semi-structured interviews with stakeholders from the Department of Education, Department of Health, Department of Social Development, and caregivers of children living with mental health conditions in the Hamajuba district of the KwaZulu-Natal province. And then we conducted two stakeholders participatory workshop. One was a physical workshop, and the second one, the follow-up workshop, was a virtual workshop. And so the study findings revealed 6 major bottlenecks. That's the preliminary findings from the stakeholders' interviews and from the situational analysis. So we identified 6 major bottlenecks to accessing child and adolescent mental health services in the district. And it was majorly poor management structures. There was an intersectoral collaboration or forum of where all the different sectors involved in providing services come together to engage and to discuss solutions to the challenges they were facing with providing child and adolescent mental health services. The second was poor identification, screening and assessment at the community level. There was almost no intervention or strategy for to promote early identification within the community and even the school setting. There was also inappropriate referral. We found out that children are mostly with learning challenges, were mostly referred to clinical psychologists, who should have been referred to educational psychologists. So there was the issue of inappropriate referral, and that sort of lengthens the waiting time and the period to actually access the required or the needed services. And there was limited task sharing. There was limited community-based child and adolescent mental health interventions, and there was limited child and adolescent mental health promotion and awareness programs at the district level. And so we compiled these findings, like I said, from the preliminary engagements, the interviews, and the situation analysis. Then we went on to present this to the stakeholders that we had previously interviewed in a participatory workshop. And what we did was then ask them to validate our findings from the interviews and the situation analysis if they agree with these bottlenecks, and then ask them what are the causes of these bottlenecks and what can we do to address these bottlenecks and improve access to child and adolescent mental health services and the quality of child and adolescent mental health services that are provided in the district. And so the engagement from the workshop led to this theory of change map. During the workshop, we had asked them for the different strategies, the short-term outcome, the medium-term outcome, and the long-term outcome, and also input and output strategies to improve child and adolescent mental health services in the district. So the long-term outcome is to improve. The long-term outcome is to improve child and adolescent mental health services, and these are the major strategies that will lead to improved child and adolescent mental health services. And the first one is early identification. Early identification. And also I'd like to mention that all these strategies are divided into different settings. We have the community settings, which includes the home environment and the school environment. We have the primary healthcare setting, we have the hospital setting, and we have interventions or strategies that are cross-cutting, that cut across all the various levels of care. And then you'd see that the boxes are in different colors. The yellow color are strategies that are focused, that are Department of Health and Department of Education focused, and the boxes in green cut across all the sectors. The boxes in red focused on Department of Health and Department of Social Development, and the boxes in purple directed to the Department of Health. And then the brown boxes are the Department of Health, Department of Education, and NGOs and community-based organizations providing services in the district. And so the stakeholders mentioned 4 major intervention areas that need to be prioritized to improve child and adolescent mental health services in the district. And they include early identification, appropriate referral, development of care packages, multi-sectoral care packages, and then intersectoral governance. And so, like you'd see that there are different suggested strategies for early identification. They had suggested the development of a screening tool that can be used at the community level by non-specialists. So it will serve as both a psychoeducation tool and a screening tool within the community that community-based health workers could use, or educators within the school environment could use. And this would actually improve the quality of screening and also, inform referral of children to the appropriate site of care. And also the need to educate parents and the community at large on child and adolescent mental health conditions to prevent, stigmatization and discrimination and all within the community, and also help caregivers identify these conditions on time and actually seek help for the children. And the need to also improve developmental screening at the primary health care level is identified. They need to improve quality of child and adolescent mental health assessments within the primary health care using trained psychiatric nurses within the primary health care setting. And within the hospital level, a prompt access to child and adolescent mental health assessment and diagnosis. And this would then lead to appropriate referral, because if these interventions are picked up on time and people who picked it up are adequately informed on how to refer and where to seek help, this would then promote appropriate referral. And on the appropriate referral, stakeholders had suggested the need to educate the community to improve their health-seeking behavior for mental health conditions, particularly with children, and the need to ensure the availability of trained child and adolescent mental health nurses at the primary health care centers, and the need to also clearly define referral pathways to clinical psychologists or counseling psychologists or psychiatrists or occupational therapists or speech therapy needs to be designed such that children are not just referred and then sent back to other specialists, thereby elongating the waiting time and the time required to seek help or to actually access services. But if the pathways are clearly communicated, then this would actually prevent inappropriate referral. And cross-cutting interventions would be to design a multi-sectoral child and adolescent mental health referral pathways so that people in the school environment understand where children with learning disabilities should be referred to, and children with internalizing disorders or externalizing disorders should be referred to. And the need to communicate. We found that there are different policies within the different organizations, the different departments that, each department are there to or use in referring or in diagnosing or assessing patients. And so there's a need to communicate all those policies with all the sectors and sort of integrate those policies so that we can achieve a multi-sectoral child and adolescent mental health system in the province, at the district and in the province. And this would then lead to the development of a comprehensive child and adolescent mental health care package for children in the department. So there's a need to design community-based interventions, particularly programs to educate parents, to support educators, because They also at the receiving end of these conditions. They often get frustrated and impacted with the conditions and that of their students, and also conditions of their children when it comes to caregivers. So there's a need to develop interventions for different categories of people providing care, and even children and adolescents experiencing these challenges or this conditions. There's also the need to initiate psychosocial support for children, adolescents, and their caregivers. So caregivers had mentioned feelings of exhaustion and depression and not helplessness, because there are no particular interventions to cater for their needs, while caring for children with mental health conditions. And the need to also improve treatment initiation is also very important, because participants had mentioned that children could be on the waiting list for as long as 6 months and even more before accessing care. So there's a need to improve treatment initiation at the primary healthcare level in particular, adopting a task sharing approach to providing child and adolescent mental health services could be very valuable. And also the need to design packages, like I'd mentioned already, was also emphasized by the stakeholders. And the bedrock for all this was intersectoral government. If there is no stakeholders buy-in from all the departments, and if there are no multi-sectoral strategies developed and implemented to achieve improved child and adolescent mental health services, then we would not get there. And also there's a need to then create a committee or a working group, a multi-sectoral working group to actively engage with the challenges encountered in delivering child and adolescent mental health services, and how this can be improved. How this can be improved in the district. And also there's a need to discuss budgeting and funding for implementing services at every level of care when it comes to child and adolescent mental health services. Trying to move to the next slide. I don't know why I'm struggling to move to the next slide. Can I stop sharing quickly and see if I can resolve this? If I can just go on without sharing, I'll just move to the next slide.
We can see your slides.
Now, okay, thank you. I think I'll just leave it here because it becomes really problematic with the bigger screen. Okay, so after this engagement and after we had put up this a theory of change map, we then presented this back to the stakeholders in a virtual follow-up workshop, and then asked them to identify what would be the priority interventions that should be designed or developed immediately. And they identified 4 immediate priority interventions that is needed in that district. And I think that it would also be important to learn from this district, as it could also be implemented within the province and nationally. And the first one is Child and Adolescent Community Awareness Program. There's a need to improve mental health literacy in the community. And this goes beyond even child and adolescent mental health, and it goes beyond, it's also a mental health at large. How much information is out there to educate people on mental health conditions, and now particularly child and adolescent mental health conditions. And also the need to develop psychoeducation interventions. The need to train educators across the different phases of education was also highlighted, even from the elementary, from from the crèche up onto primary school and to secondary school was also highlighted. And many of the stakeholders, particularly stakeholders from the Department of Education and community-based organizations, NGOs working in that district, have emphasized the need to train educators, because children were mostly identified in the school environment. It's in the school, children were often, those conditions were often picked up during school years, like during the school age. And then children are either sent to the clinical psychologist or to the psychiatric department in the hospital, whereas some of the children were dealing with learning disorders or learning conditions that should have been referred to educational psychologists or other specialties that could assist the children. And because there's a long waiting list with the clinical psychologists, it took longer to attend to those children. And they continued, to suffer and to, encounter academic challenges in the school environment. And so the need to train educators, the need to capacitate educators was really emphasized during our engagement with the stakeholders.
Dr. Mokatimi, sorry to interrupt, just to say you have 4 minutes left.
Thank you. And the need to screen, to develop screening and psychoeducation tool that non-specialists can use within the community was also emphasized. And the need to define, to design and define referral pathways to care for children and adolescents was also emphasized. And I just want to talk about our engagement at the Center for Rural Health. We're currently busy with, based on the request of the district, we are currently busy with developing a psychoeducation and a screening tool that will also serve as psychoeducation tool for children and adolescents mental health conditions that can be used by community health workers and can be used by educators in the school environment to ensure appropriate referral and to ensure that these conditions are identified early enough to seek interventions or services. Now, our recommendations would be to establish intersectoral collaborative learning hubs with education institutions, Department of Health, Department of Education, and the NGOs involved in providing child and adolescent mental health services in the districts, at the province level, and at the national level. And the need to integrate child and adolescent mental health services along the care cascade and the process for managing other health conditions such as eye problems and hearing problems. Because mental health conditions are not getting as much attention as these other conditions. And so if care is integrated, mental health gets integrated into all this care cascade, then maybe that would help. And the need to also develop a research consortium for child and adolescent mental health research is also very important. And the need to work in 1 or 2 implementation districts as a learning site. That brings me to the end of my presentation. Thank you.
Great, thank you very much indeed, Dr. Babatunde. Thank you. Very interesting work that you've been doing in the Amajuba district in KwaZulu-Natal. So we are getting a lot of interesting questions and comments coming in the Q&A. And I just want to encourage everybody to keep posting questions. We'll be hearing from each of the speakers first, and then we'll have a time for questions and discussions. So if the panelists can also just keep an eye on that Q&A, feel free to type in responses, and we'll have a conversation going on the Q&A as well as while the talks are being presented. All right, so I'm going to now ask Dr. Simpiwe Simelane to speak to us next. Dr. Simelane is a PhD student at the Center for Autism Research in Africa at the University of Cape Town. She joined the department as a researcher in 2021 after being selected for the SAMRC Clinical Researcher Program. She's a medical doctor by training and completed her internship in Cape Town and has done community service in the rural communities of Tonga in Mpumalanga. So she's somebody who really has her feet on the ground in terms of public health experience and is developing a research career in mental health for children and adolescents. So Dr. Simelane, over to you. Please, the floor is yours.
Thank you, Greg. I'm just going to share my screen. Good afternoon, everyone. Today, I'll be talking about how we can move research on child and adolescent mental health services and systems from mapping the problem to strengthening the system. Few people know that mental disorders are a leading cause of morbidity in young people. Before we talk about that, it's important to note that mental health and illness exist on a continuum. This ranges from being healthy on the one end of the spectrum to being ill on the other end. Different healthcare activities and services may be applicable to different parts of this continuum, including promotive, preventive care, curative care, and rehabilitative care. But even with the best possible mental health promotion and prevention strategies, lower rates of violence and poverty, and access to well-developed CAM services, some children and adolescents will still develop a mental or neurodevelopmental disorder. There's no good prevalence data on child and adolescent mental health, but worldwide data estimates that 10 to 20% of children and adolescents will develop a mental disorder before the age of 18. If we use the conservative estimate of 10%, this means that approximately 2 million South African children will have a diagnosable mental disorder. Unfortunately, there's a huge discrepancy between the proportion of the population that has a mental disorder, the prevalence, and the proportion of those that actually receive care. This is known as the treatment gap in mental health. This is worse in low and middle income countries and worse for children and adolescents. South Africa is an upper middle income country, and the mental health treatment gap in South Africa is estimated to be 90%. This means that only 1 in 10 people who need care actually receive it. The discrepancy in human resources for high compared to low and middle income countries can be used to illustrate this point. The most recent WHO Mental Health Atlas, which was published in 2021 for 2020, found that the median number of health workers for children and adolescents per 100,000 of the population was 1.5 in low and middle income countries compared to almost 20 in high income countries. If we take a closer look at South Africa, we can find examples of this treatment gap across the WHO health system building blocks. Mokatimi and colleagues recently conducted a situational analysis of child and adolescent mental health services and systems in the Western Cape. And these are some of their key findings. There were no dedicated child and adolescent mental health services at the secondary level of care, no specialist child and adolescent mental health services in rural districts, and very limited psychosocial treatments available at primary and secondary levels of care. In the health workforce, there was no documentation of training of primary care staff. They found that there was no disaggregated or accessible data on child and adolescent mental health. And they found that there was no dedicated financing for child and adolescent mental health. They also found that there was an outdated national policy for child and adolescent mental health, but no provincial implementation plans. On a positive note, they found that there was access to at least one drug from each psychotropic medication class of drug at each level of care. So there was good access to medication. And although it was not so at the time of the study, the Western Cape has recently appointed a provincial lead for child and adolescent mental health to oversee and coordinate services. It's clear to see that we have many challenges in child and adolescent mental health services and systems in South Africa, but we now need to move from describing the problem to coming up with solutions. And with such a mammoth task ahead of us, the only way to tackle it is one bite at a time. As we try to address the challenges in child and adolescent mental health services and systems, it's important that we have a systems approach to the problem. According to the WHO health system, health systems can be broken down into 6 building blocks. These are service delivery, the health workforce, health information systems, access to medicines and technologies, financing, and leadership and governance. However, just like a pile of bricks is not a building, one cannot look at the building blocks in isolation. The WHO building blocks provide a good framework for us to be able to understand the components of the health system that we need to address. But it's important to bear in mind that health systems are wicked problems. This means that they are complex adaptive systems with fuzzy boundaries. Research in strengthening health systems won't be a neat linear process, but one that requires dancing with the system in order to adapt as challenges and unforeseen consequences emerge. Instead of the traditional input black box output process, systems thinking will require a shift in focus to the nature of relationships of the building blocks and the synergies that emerge with their interactions. This helps us to understand that all the building blocks are interlinked, and that as we intervene on one building block, there will be knock-on effects on the others. Preempting these interactions can't prevent the knock-on effects, but will hopefully allow us to optimize the whole system and mitigate against negative consequences. Traditionally, stakeholders and researchers have done work in silos, focusing on specific problems rather than on the system. System-level interventions target one or more building block rather than a specific health problem. And a crucial component to this process is stakeholder engagement. All the actors need to be invited to the table and should act as co-producers in the process of formulating a solution. And they should know what their roles are during the implementation and scale up of interventions. In CAMS, this can be a bit more complicated because there are so many different stakeholders in the system and so many different levels to the system. This includes not only the Department of Health, which I have divided into researchers, healthcare providers, managers, and policymakers, but also the Department of Education, the Department of Social Development, the Department of Justice and Correctional Services, the Department of Finance, and private, public, and nonprofit sectors. Although this makes research in strengthening child and adolescent mental health systems more complex, it's important that all of these stakeholders are involved, as they will be the ones to drive its implementation. And therefore, their input and buy-in is crucial for the success of interventions in CAMS. This does not mean that all the players have to be at the table at once, but it does mean that attempts should be made to consult different stakeholders, and that there should be good communication between researchers, policymakers, and providers tackling different elements of the CAMH system to ensure that the priorities are aligned and that they work synergistically to strengthen the whole system. It's important to note that there is an often forgotten stakeholder who is typically only involved during the implementation stage of research, rather than throughout the process. Patients and caregivers offer invaluable experience through their lived experience and of illness, services, and systems, and should be consulted from early on in research. They actually play multiple roles in the health system as patients who use the services, consumers with demands, citizens and civil society, taxpayers who act as a source of funding, and co-producers of health through their uptake of the health services. Not included in this diagram is their emerging role as an interventionist, as they are increasingly being used or taking part in task-shifting strategies. As we take our next steps towards strengthening health systems, we can divide our efforts and research using the future funnel, with low-hanging fruit being those interventions that will take little effort and can likely be implemented immediately at the facility level. Some interventions which will require effort, ranging from planning and coordination to optimize existing resources to the development and implementation of new innovations, and dream concepts, which will require major reforms. Here are some examples of what is being done in other low and middle income settings. Under service delivery, task sharing and public education and school-based programs and digital support systems are being used. An example of this is the integrated youth depression program in Tanzania and Malawi, which worked at different levels. Public awareness was raised through a youth-friendly dramatized radio program, which was coupled with a program rolled out in schools by teachers, where they covered programs from the radio program during the week, and they were equipped to screen adolescents and refer them to the local facilities. Community health workers in those facilities were then trained on how to give psychosocial therapies. This is an example of how a health system strengthening approach can be used to target multiple levels within service delivery. Another example is digital support systems. In India, an automated clinical decision support system has been developed where clinicians or primary care providers at primary health centers are able to use this interface for supervision and for training purposes. So they're able to be walked through the management of a patient from assessment to treatment with the computer program rather than one-on-one support from a specialist. Other examples in the health workforce are validating screening tools, which can be used by health workers at lower levels of care, and training of non-specialist providers. Another example of training of non-specialist providers is one from Uganda, where a postgraduate program was developed to train multidisciplinary teams from peripheral districts who were trained in camps and then sent back to their district. This resulted in a more than 10-fold increase in the number of children that was seen in CAM-H services over 6 years, between 2012 and 2019. Financing strategies include the development of different financing models or economic strengthening to try and alleviate the social determinants of health, such as cash transfers, which are being investigated in Uganda and Malawi, where adolescents are given access to cash transfers to try and alleviate poverty in an attempt to increase their well-being.
Dr. Simelane, sorry to interrupt, just you have 4 minutes left. Thanks.
Okay, thank you. So in conclusion, health system strengthening requires complex solutions to messy problems. It will not be a straightforward process and needs all the voices or stakeholders to be heard. It will require a combination of bottom-up and top-down strategies and tackling the problem through different angles with good coordination and communication about the work being done. I'd like to acknowledge my supervisor, department, and my sponsors. Thank you.
Great, thank you very much indeed, Dr. Simelane. Really interesting presentation and really interesting to hear the strong emphasis on a systems approach, which I think actually fits very nicely with Dr. Babatunde's example as well of working in rural KwaZulu-Natal, which has very much also adopted a systems level approach. So thank you very much. Again, we'll hold questions, and thanks for those of you who are posting questions in the Q&A. We'll come to those after everyone has spoken. So next is Dr. Stella Mokatimi. Dr. Mokatimi holds a PhD in psychiatry from the University of Cape Town. Her thesis was entitled Child and Adolescent Mental Health Services in the Western Cape of South Africa, Situational Analysis, Policy Evaluation, Stakeholder Perspectives, and the Implications for Health Policy and Implementation. She has 23 years experience working in mental health services and is currently working for the Western Cape Department of Health as a clinical program coordinator in the Khayelitsha Eastern substructure. So Dr. Mokatimi, you're very welcome, and we look forward to hearing from you. The floor is yours.
Thank you so much, Quick, and good afternoon to you all. Let me start sharing my screen. Okay, I am going to present the innovations to strengthen child and adolescent mental health services in low-resourced communities. Let me take you back to my PhD study, which used a multi-level synthesis model to understand child and adolescent mental health services. I looked at the policy landscape, looking at the available child and adolescent mental health policies at national level in our country, in South Africa, across all 9 provinces. And the findings, some of the findings, Sipiwe has already mentioned. And next, I looked at the resource landscape, looking at the current situation of child and adolescent mental health resources at provincial level in the Western Cape of South Africa, as mentioned some of the findings. And I also did a SWOT analysis of child and adolescent mental health services, looking at the strengths, weaknesses, opportunities, and threats for child and adolescent mental health services, engaging with senior stakeholders in the Western Cape. And the last leg was exploring the views and perspectives of the grassroots level stakeholders, being the grassroots level service providers of child and adolescent mental health services, as well as the users, being the children and adolescents, as well as their caregivers. So we explored their lived experiences, and we asked them about the challenges that they're experiencing in child and adolescent mental health services. And we also asked them to come up with recommendations to strengthen the service. One of the key findings, which is speaking to the innovations, taking it one bite, as Simpiwe has mentioned today, is the lack of dedicated child and adolescent mental health services at primary and secondary level of care. As we know, at primary level of care, what is happening, children and adolescents do not have separate services. Their services are mixed with adult psychiatric services. And at secondary level of care in inpatient units, those who are requiring emergency care, the under 12, they're admitted in pediatric wards, and the 13 to 18, they are mixed with adult psychiatric patients in the inpatient units. And this mix doesn't come without a negative impact at all. Our service users have reported
It looks like we're having a problem with Dr. Mokatimi's line. Can anybody else not hear Dr. Mokatimi?
We can't hear her, Prof. She did mention that she is load shared. So she's trying to reconnect.
All right. I think let's just wait a few more seconds, and then if she can't, I think we'll go on to the next speaker. If you can, everyone just bear with us. I think maybe in the interest of time, what we should do is just move on to Prof. Mark Tomlinson, and then maybe we can circle back to Dr. Mokatimi when she reconnects. So welcome, Mark. For those of you who don't know Professor Mark Tomlinson, he's the co-director of the Institute for Life Course Health Research in the Department of Global Health at Stellenbosch University. And he's also a professor of maternal and child health in the School of Nursing.
Okay.
At
Yes.
Queen.
Sorry, I was disconnected. There's load shedding this side, so it's on and off. So I want my child to deal with me. Is it okay if I continue?
Yes, I think carry on, Stella. Sorry, Mark.
Yes, let me carry on a while before it kicks me out again.
Okay.
I'm gonna share the screen. Thank you so much. Let me move. So the situational analysis, as also mentioned by Simpiwe, that I conducted in 2016, the findings concur very much with literature showing that us in the Western Cape also, we do have a treatment gap of 90%. Fewer than 10% of children and adolescents access the service. And actually what is interesting is that of the 10% that is able to access the service, they access the service in tertiary specialist units where they receive more effective care. So as we asked our grassroots level service providers and users, we asked them to come up with the practical tips to strengthen the service. And we also asked the service providers about the current services that they are providing and what they are doing with limited resources. How do they manage to provide effective care despite the lack of the resources? And we incorporated all these recommendations into formulating these practical tips to strengthen child and adolescent mental health services within the existing services, particularly at primary level of care. Now I'm focusing on the low-hanging fruit and taking one bite at a time, as Simpiwe has said. So these practical tips, number one, it's about creating dedicated child and adolescent mental health spaces within the existing mental health services. Second one, making the space child and adolescent friendly within the service. Separating the time of child and adolescent clinic from adult mental health patients. Creating links with other departments within the facility in order to get support for child and adolescent friendly services that one has created in their facility. Organizing child and adolescent clinic to deliver more effective services, and providing training in child and adolescent mental health services, encouraging the staff to propose innovations to strengthen child and adolescent mental health services, and actually acknowledging the staff for the work that they are doing. And lastly, setting up a clear plan for communication with and training of parents and caregivers. Now, how do we move from research to practice and focusing mainly on the low-hanging fruit? We implemented these innovations in the Western Cape, mainly focusing in the Department of Health at the Khayelitsha Eastern Substructure, which is a low-resource community with high rates of poverty, crime, and substance abuse. We also focused on the formal mental health services and mainly a primary level of care in the clinics. So this is what we did. Firstly, I engaged with the key stakeholders, which is the community mental health nurses, facility managers, and operational managers, in discussions about the importance of separating children from adult psychiatric services, in orientating them about the new mental health service structure that is to be implemented. Also to facilitate support for the mental health nurses from the management, and also to provide training. Training focused on the group, and it was also provided at individual level at each one's individual facility. And on developing the mental health service structure, on reviewing the child and adolescent caseloads that each one is carrying, determining how much time does one have to spend on an allocated caseload, and also choosing a slot for children and adolescents far away from the adults. By the end of 2021, we were at about 90% implementation of the new structures that allow for separate child and adolescent mental health services from adults. By the end of January 2022, we were at 100%. Currently, all our facilities are having separate slots for children and adolescents. So each clinic, they choose whether to provide services in the morning or in the afternoon. Those who choose in the morning, depending on their context and the needs of their users, they prefer to see children in the morning so that they go to school. Those who are seeing them in the afternoon, it is to enable the children to go to school in the morning and come to the service in the afternoon. After that, I developed the standard operating procedures in collaboration with the mental health nurses, facility managers, and operational managers. And then I conducted a training, which is still continuing virtually and on face-to-face, focusing on increasing capacity of mental health nurses, looking at the topics like diagnostic assessment, how to conduct an interview with the child, how to use the assessment tools and the referral care pathways. And I also started developing links with specialist child and adolescent mental health units, again, to facilitate training and support. This is to show you an example of the new mental health service structure that is in operation in all our primary healthcare facilities. This is a template. As you can see, on a Wednesday, there in red, you see a separate child and adolescent mental health clinic. No adults attend during this time, only children are seen in the facilities. What is the next step? I'm looking at ensuring that the resources for children and adolescents for assessment and intervention are available in all our primary healthcare facilities. I've started collaborating with the newly appointed Provincial Child and Adolescent Mental Health Coordinator, Dr. Nassim, to facilitate support and to work together to strengthen these services. It is important that these clinicians receive clinical supervision, and I need to make sure that they receive supervision which is specific, not just to mental health, but to child and adolescent mental health. Again, as the caseload will be increasing in these facilities, it means that time allocated to the separate child and adolescent mental health clinic will need to increase, and we will also look at that. Lastly, it will be monitoring and evaluation and the review of the standard operating procedures at the end of the year when the due plan and review session is occurring. And lastly,
sorry to interrupt, you have about 4 minutes left. Thank you.
Thank you, thank you. And lastly, evaluation will be done through research where I'm looking at developing a service model specifically for community child and adolescent mental health services. I thank you, and I'd like to acknowledge my supervisors of my thesis, Professor DeFees, Professor Schneider, Dr. Kim Jonas, who assisted a lot in the analysis of the qualitative data, and all my funders and the service providers who have made this possible in the substructure, and our director was very supportive of this process. I thank you.
Great, thank you very much indeed, Dr. Mokatimi. Really exciting to see what's possible and what you've been able to achieve in the Khayelitsha Eastern substructure. So we're looking forward to hearing comments and questions from everybody online. All right, so let's move on then to our next and final speaker. Professor Mark Tomlinson, as I mentioned, is the co-director of the Institute for Life Course Health Research in the Department of Global Health at Stellenbosch University. And he's also a professor of maternal and child health in the School of Nursing and Midwifery at Queen's University in Belfast. His scholarly work has included a diverse range of topics, including how to improve early childhood development, child and adolescent mental health, maternal mental health, and developing life course approaches to building human capital in the first 2 decades. So Professor Tomlinson, it's really a great pleasure to welcome you to the webinar today, and the floor is yours. Thank you.
Thanks, Crick. Can I just confirm that you can hear and see the slides? You mean see the slides?
Yeah, and we can hear you. Great.
Great, thanks. And thanks to ASA for the opportunity to do this talk. I mean, I'd also like to thank the 3 excellent presenters before me, because they've set a really nice scene for me to one of the joys of being a bit old and grumpy and kind of being the last speaker. I took a little bit of liberty in terms of where I might go with this talk, and so it was really nice to have the 3 presentations first to really speak about the situation on the ground, the services, what's needed. I'm going to try and do something slightly different. And I felt it important to think about the world that we currently in when we think about children and adolescents. And I put these 3 pictures up as just 3 pictures, and there's many more I could have put up of current conflicts in the world. Some pictures you may even have recognized the pictures. It's a picture from Tigray, a picture from Syria, and a picture from the Ukraine. And while they're incredibly diverse in different contexts, there also are places where children and adolescents suffer considerably. That figure down there, 10 million children younger than 5 years dying in conflicts between 1995 and 2015. And so those are the extreme cases of war and conflict. But we also know that the children bear the brunt of many things. They bear the brunt of inequality. That World Bank report there was published, I think, earlier this week, and yet again showed South Africa to be the most unequal country in the world. And children suffer from poverty, from having education and learning opportunities interrupted. Michael Kamapi, that picture at the top there, falling into a pit latrine in fairly recent history. So children bear the brunt. So what does that mean in terms of mental health? And I like using this continuum. We used it in a report a couple of years ago that Lorraine Shirley, Lucy Kluver, and myself put together for UNICEF, but it's commonly used. It's not our invention or anything. And basically it says that all of us, all adults, all children and adolescents, will find ourselves somewhere on that continuum. Importantly, though, where you are in the continuum isn't a static thing that stays the same, that you can be psychologically healthy and mostly unaffected by stress, by anxiety, by mental health distress or symptoms. But then, of course, there's a loss, a bereavement, unemployment, and you may move. People may then move to still be psychologically healthy, but now be experiencing stress. If that continues, becomes chronic, we then may get new cases of subclinical mental distress. That, of course, then may move into existing and new common mental health conditions. And then, of course, at the extreme end of the severe psychosocial disability, so a severe case of depression, psychosis, and very severe conditions. Now, outside of that far end of the continuum, and even there to some extent there's some fluidity, but there's an enormous fluidity in here. But that's not the way that the media constructs it. That's not the way that many people think about it. Often it's very much in a either or. You're either well or you're not. You're either depressed or you're not. And in terms of adolescents particularly, but children as well, their movements as adolescents struggle with issues of identity, their place in the world. They may exhibit a lot of these, but not be in need necessarily of mental health care, but then may move into situations where they do. And I would propose that we're not very good at knowing that difference. Equally, what COVID has shown us is that what happens when we have a pandemic or a conflict or a situation is we tend to understandably panic, and we then want to respond to the pandemic, somehow as if there weren't many pre-existing conditions that make it very likely that children and adolescents were struggling in the world, whether it's from toxic stress, violence, poverty, social conditions, background health, and there are these pre-existing conditions which are often forgotten about somehow. We look importantly at the immediate impacts of a pandemic. Obviously, the lockdown had many of those, but we need to separate into. We need to continually think, I think, about those pre-existing conditions, the risks, when we consider new situations such as a pandemic. But part of what I want to focus on, and I will speak, I promise, to some ideas or priorities for child and adolescent mental health research. But equally, I want to talk about the broader contexts, and the importance of not seeing well-being, not seeing distress, not seeing mental illness, mental disorder, mental health as solely residing in the brain, in the head, in the body of children, adolescents, and in fact of everybody. That in fact the social conditions, the social environment are utterly vital in this regard. So we know COVID-19 is obviously a new crisis, but HIV has been a crisis for over 30 years. It just hasn't been a crisis outside of the beginning for rich countries largely. It's been and so it's been to some extent neglected. But many of you on this webinar would probably agree when I say that mental health is a long-standing care crisis. And I mean care not just in the care of people at the far extreme of that, of the continuum I put up just now, but equally along that continuum, and how we scaffold, how we prevent, how we promote, and not only treat this. So what we do is we shine a spotlight, and it's COVID or it's HIV. We have this spotlight. We in a sense, to some kind of neglect all the other factors, and then what we do is we try and have a quick fix. So COVID has led to increases in anxiety, so we must now reduce levels of anxiety. Now, of course, I'm not saying that reducing levels of anxiety is not a good thing. Of course, it's a very important, vital thing. But very often our solutions are quick fix, and it's a band-aid over a deep fissure or crack in our societies. And so now I want to make a pitch for this book, which I think is one of the most important books that's been published in quite a long time. And it's called Inflamed, and it's by Rupa Maria and Raj Patel. And essentially, it's making an argument, and the word inflamed is playing on two things. The one is the inflammation that we know increasingly is related to so many diseases, to COVID, and to mental illness, that in context of poverty, toxic stress, chronic trauma, that basically our bodies, our brains become inflamed, which makes us incredibly much more vulnerable to then later insults such as COVID. So the increased rates of death from COVID in many marginalized groups globally, and this is not just about South Africa, there are lots of reasons for it, but one of the reasons is a vulnerability based on the inflammation of the body. And so Rupa Maria and Patel, they play on this term to say, we've created these societies which are making people sick. And then they get sick with the virus, and then somehow we think the solution is a vaccine, and of course that's part of the solution, but in fact it's much more. And that what we need to do is we need to become inflamed, and we need to become incredibly angry about the ways in which poor, marginalized people's bodies are being inflamed by the societies in which we've created, in which we live. And so they, for example, in the book say that COVID, for example, is overexpressed in socially oppressed groups. And I'll posit, and again, I'm certainly not the first one to do this, and Crick, in fact, has done much of the work on social determinants of mental illness, but mental illness is also overexpressed in socially oppressed groups. And the solution cannot just be found in the viral agent or in the symptom. It has to be found in addressing the underlying factors in that oppression. And before I move briefly onto what I would say is what I think is a paradigm shift needed, I wanted to just put a couple of, in the context of what I've just said, to list three here and one on the next slide, about priorities that I think are absolutely crucial in South Africa. The first is that we actually don't have prevalence data in South Africa. Without data, there's no way to plan services. So we don't have a national representative prevalence study. Crick and Sharon Kleincheese and others did an admirable attempt a number of years ago to model that. But what is that about? And I'll touch a bit on that later as well. But how is it that we don't? And I think that's absolutely key. Globally, there's a shift and a move to increase child participation, and not child and adolescent participation as a tick box, but to really recognize and support their agency and bring them in at the start of everything that we do. Our group, our team at the Institute is currently working with an organization called Cities Rise with money from the Wellcome Trust, doing work in India, in Rwanda, in Kenya, and in Cape Town, where we use youth researchers to do work with adolescents around mental health. It's around the channels they trust, the actors they trust to get information about mental health. And we know about social media. So is that their trusted source? Who are the people that they go to? Is it influencers? Is it their parents? And this work is happening in these 4 sites. Given what I said prior to this slide, I think the research, an important area of research we need to be engaged with is creating more enabling environments, to create more resilient environments for children and adolescents. And I want to say this again, I'm not for a minute saying that clinical services aren't key. I'm assuming that you've listened to 3 previous fantastic presentations about services and how they're understaffed, under-resourced, and that's absolutely key. I'm talking about how we find ways. We know, for example, and this will speak to this slide, and it's very busy, and I'm not going to go through. I just put it up because it's about the life course. We know that the majority of later adult mental disorders have their origins during childhood, but we're not good at early detection. We're not good at working out which children, which families need support now, which need more support later, in order to prevent the later occurrence, to better support those children, those families. And we particularly bad at creating environments that aid that. So children and adolescents living in environments that are full of poverty, full of violence, full of pollution, and that are then as a result are in food insecure environments, are vulnerable to a whole host of things. And mental illness, mental disorders are only 1 or 2 of the poor outcomes that they are more vulnerable to. So we have to be thinking of longitudinal intervention research that accepts the well-known research finding that these disorders start early. We know that children and adolescents, as I said, move along this continuum. How do we create the environments to stop children moving further and further down that continuum, whether it's into substances, whether it's into alcohol, or whether it's into serious mental disorder? And for the last 5 minutes, I want to make a pitch for what I believe is a paradigm shift. And I want to say first, thank you to Willem de Jager for his question right at the beginning of this webinar, where he asked, so yes, we know that it's a fact that children and adolescent mental health services are neglected. So, but unless we work out what's the reason for the neglect, we're probably going to be very, very unsuccessful in unlocking more resources and unlocking funds in a different way of looking at this. And Crick kindly put a paper up there, or you'll see it in the question and answer, that he and I wrote many years ago. It wasn't specifically about child and adolescent mental health, but it made an argument for why mental health does receive less attention. But I want to take a broader view, and I think we have a very, very big problem in how we understand children and adolescents. And many of you will know some of these books that I put up here, where there's been a large academic body of work on conceptualizations of childhood that showed, for example, in Victorian England, childhood essentially ended at 7, when children then had to go and work in industrial factories or in the mines. The idea of this extended childhood through adolescence simply didn't exist. There have been other studies on how in many cases, because of higher levels of childhood mortality, children aren't named until a certain age, for example, and there's some controversy around that research. But there are these constructions of childhood which have incredibly, powerful implications for then the policies we make, for where we put money, and for what we then neglect. So possibly the most controversial book there is that middle one called Confronting Prejudice Against Children, called Childism, written by Elizabeth Young Brule a number of years. And she's largely speaking about the United States, but she argues that the way in which children are treated, the way in which the interests aren't regarded, the way in which they're not considered properly in making decisions about their lives, that in fact should be up there with racism and sexism and the other isms. And that it says a lot about then the decisions we make about where we put money and how we fund things, or the policies we make. So a number of years I was part of this Lancet Commission, and our main aim, and there were many within that, was really to make a case for putting children at the center of all policies. So thinking about the future, not just the future in 5 years, but the future in the next 50 years for children, and what do we need to do? Following the Lancet, this organization, Children in All Policies 2030, was formed. It exists to this day, and there's a number of strands within that. I'm not going to go into that right now, but essentially in that commission we were making the argument that we know about many of the risks. We've seen lots of improvements in health and education in recent years, but we focused in that commission on 2 particular threats: environmental threats and commercial threats. So obviously the environmental one is climate change, climate breakdown, and commercial threats. And to loop back to, for example, that inflammation, we know as well that inflammation, one of the biggest causes of inflammation is sugar, for example. We know the implications of that for health and development, and in some ways for mental health. And we said that it is an emergency. We're not. This is not just a mild risk. We're in the midst of an emergency. And I thought this was interesting, given the climate change. It's a fairly recent paper from the Lancet Planetary Health, and a correspondence, a letter in response to by a number of authors, one of which is Sarah Dalglish, who in fact is the head of the Children in All Policies. And it basically looked at climate anxiety in children and young people. In terms of research, we could go, and I think this is very important research, but we could start designing lots of interventions to reduce the anxiety, for example, of the 75% of children and young people, 16 to 25 years, who in the study spoke about being frightened about the future. So we could go and design a lot of interventions to reduce anxiety. But in fact, and again, I'm not saying that that's not important, but the reality is as well is that we need to confront climate breakdown. We need to confront the corporations. We need to confront the countries that are messing up, for want of a better phrase, the future for our children. And so we do need an entirely new paradigm shift, I think, that we require a strategy that puts children and adolescents at the center. And I mean at the center of all policies, because the moment you put a child at the center, you, by definition, you aren't excluding the grandmother because of the important role she will play in the role of that child. But what you're doing is you're not forgetting children, and we do that routinely. And you only have to look at what's happened in COVID to know how incredibly, I would suggest, damaging is that being. Is children and adolescents have been utterly ignored. It started because they were at less risk from the actual virus. But public health is always a balancing act. Public health is not a win-win. You're always balancing. Children were not even on the scale. Children and adolescents. We protected as we needed to. Elderly people, we protected other immunocompromised people, and that needs to continue. But I would suggest that children and adolescents weren't put on that scale at all. We didn't balance anything. And so there hasn't been a sense in which we've said, what are the damages to long-term education prospects and therefore employment prospects? And we know that if, and food insecurity, for example, and we know that if a child is stunted with few educational opportunities, that the implications for their mental health and for their developmental potential across the life course are severely curtailed. So we haven't done that. And so we need to take the needs of children and adolescents, and they need to become a lens through which decisions are considered and made. And I think this has to happen, and it is an emergency in both the short and the long term. Thank you.
Great, thank you very much indeed, Mark. Some really important points, and I think some really valuable perspective, drawing our attention to the broader contextual issues. And I think really as advocates for child and adolescent mental health, we need to be really not only addressing clinical care needs, but addressing these broader systemic and societal issues which have such a huge impact on the mental health and well-being of children and adolescents, not only now, but also in the future. So thank you so much for that perspective. Right, so thank you to all the speakers for keeping time. We now have a good 15 minutes or so for some discussion and questions and answers. And what I'm going to do is just ask the panelists if you could just make notes as I run through the questions of issues that are particularly addressed to you, and I'll give you an opportunity to respond. What I'm going to do first of all is go through the Q&A points and just read those out, and then we'll have an opportunity for people who want to raise their hands to actually speak. And I see there are 2 people in the queue with their hands raised. So let's just start with the Q&A. So I think the first question was addressed to the first speaker. Adele Monsami says, a very interesting study. What screening tool do you foresee being used at primary healthcare level? And given that specialty psychiatric nurses are not always available and healthcare workers at primary healthcare have limited knowledge and skills when using cognitive or mental health screening tools. So Dr. Babatunde, I see you are actually typing an answer, but I'll give you an opportunity to respond to that as well verbally in a moment. Then another question also to Dr. Babatunde was, how was the role of traditional healers treated, particularly in the early identification phase? And then someone, Elaine Koza, asked, could you please email all the information shared by Dr. Babatunde and everyone who will be doing their presentation? So I'm sure all the speakers will be willing to, and I hope they will be willing to share their slides or PDF versions of their slides. And we'll ask the Academy of Science to coordinate that and send it to those of you who are interested. Another anonymous attendee also asked for the presentations. Then Zon Muller says, very interesting that it was noted how obesity contributes to mental health problems. Most strategies only mention to address mental health issues through clinical treatment, but what about using strategies such as physical activity or similar interventions to mediate the origin of the problem? Physical activity has so much more benefits than just healthy body weight. And I think that was directed to you, Simpiwe. Then a nice comment from Sean Glinsky saying, Dr. Mokatimi, incredible work. Wonderful, I agree. And also Prof. Arvin Bana from KZN saying, Dr. Mokatimi's presentations are very interesting and close to valued implementation research models. So that's great. And I think there's lots of potential to learn from your experience in the Western Cape, Stella, to think about potential applications in other parts of the country. Right, and then Prof. Petrus de Vries says, I want to challenge Prof. Tomlinson on his proposal for the essential role of prevalence studies and the proposal that without data, there is no way to plan. I think we have enough data to act. To be devil's advocate, a prevalence study will be expensive, take time, and will require vast human resources. The answer will be that somewhere between 10 to 20% of children and adolescents have diagnosable and treatable mental health disorders. I don't think we need or should wait for this answer to start strengthening services and systems today. We're not able to meet the needs of even 1% of children with mental health disorders, let alone all. So Mark, I'll leave that to you to respond to. Melissa Frank says, good day, will there be CPD points awarded? I think best ask the Academy of Sciences for their response on that. Zon Muller says, thank you, Prof. Tomlinson. I'm a very firm believer in addressing the origin of the problem rather than managing the symptoms. Great, thank you. Laurie Lake says, how do the innovations and proposals for strengthening CAMS articulate with plans around primary healthcare and re-engineering and national health insurance? And to what extent are you engaging with the process of developing a benefits package? So I'm not sure who that's addressed to, but I think any of the panelists could respond. Arvin Bana again says, thanks, Mark. Always good to hear perspectives that become jaded with time. Agency is the most neglected aspect of work with children and adolescents. Thanks very much, Arvin. I really agree. Irma Elof says, thank you for the superb program. Melissa Naidu asking about CPD accreditation. And Chiamo Matabani says, I completely agree that many mental health issues are often observed in schools. Providing training to educators is really beneficial. However, are we not burdening them knowing that they already are overwhelmed with their day-to-day demands? Okay, so thank you everybody for these wonderful comments. I think around 17 comments posted in the Q&A. I'm going to do one round with the panelists and ask them to respond to these points that were addressed to them. And then we'll go to the people who've raised their hands. And I think let's just go in order of the speakers. Dr. Babatunde, do you want to go first?
Yes, I'd like to address the question relating to the appropriate screening tool in the community. So we at the Center for Rural Health are drawing from the lessons learned from implementing a tool called Community Mental Health Education and Detection Tool, CMED, and that is what we extend into children and adolescents. It's a psychoeducation tool that contains convenient stories that the community could relate to. And it's currently being implemented by the WOBOX team and not the psychiatric nurses in the primary care. So we're thinking of not using the specialists, not the nurses or people who are already burdened with workload in the primary care center, but using community healthcare workers using educators in the school environment and other non-specialists that can be, that are familiar with the community setting. So sort of using a task sharing approach to doing mental health awareness, literacy, and screening, identification at the community level. And I think Prof. Petrus also asked a question around the perspective of the school with providing education, mental health intervention in the school environment. So from my experience with engaging with educators and learning support agents, I think learning support agent, they're a special category of people that are employed to specially assist educators and students in the school environment. They were very much open to any intervention at all that can help improve the mental health of their learners. So the teachers complained about being very exhausted and worried about the mental health of their learners. They complain about students presenting with depression symptoms and substance abuse and other conditions that they cannot manage in the school environment and they have limited knowledge of. And so they actually want to know more about mental health. They long to be educated and be capacitated to provide mental health services, maybe first aid services or just any knowledge of mental health that could help them, identify conditions quickly in the school environment and also appropriately refer those children to the site of care. And I'm not sure, I think there's also another question around ESO, overwhelming teachers. There are support agents in the school environment. There's a category of employees within the Department of Education that are called learner support agents that are tasked with providing support services such as mental health services and other psychosocial services to children in the school environment. And so the educators in the school environment have suggested that this category of employees can be trained and capacitated within the Department of Education to then provide early interventions and identification and referral of child and adolescent mental health cases within the Department of Education. They need to be referred to the Department of Health.
Great, thanks very much, Dr. Babatuni. All right, let's move on to the other panelists. And if I can ask you, just keep your comments fairly brief. We have about 8 minutes left. So I think next was Simpiwe. Please go ahead.
Thanks, Bob. I don't know if that question was actually for me. I didn't mention anything about obesity and physical health, but just on the top of my head, the whole point is that I think people need to start working more together. We can't tackle the whole, so there's no one researcher or one policymaker that's going to be able to tackle the whole problem, but that we need to be working synergistically and working together. So mental health issues addressed by physical activity is something that should be addressed and can be addressed, even just in terms of increasing mental well-being, but that all of these need to start to work together, and there needs to be good communication between different researchers and in communication with policymakers, so that once something is tested out on the ground or research comes out, there's quicker uptake and quicker scaling, and so that each group that is working on something different or attacking a different area is able to collaborate with each other and work together.
Great, thanks very much, Simpiwe. All right, let's move on then to Stella. Stella, do you want to respond to any of the comments that were posted or questions?
No, thank you, Crick. I think Simpiwe has said most of it. Thank you.
Okay, great. Thanks, Stella. All right, Mark, over to you. I think there were a couple of questions that were directed your way.
Thanks, Craig. Thanks, Petrus, for the question. I wouldn't expect anything other than you to be a devil's advocate. So I'm definitely not suggesting that we don't do anything for the services or wait. But I would push back and say that, yes, it might be 10 to 20%, but it might be 30 or it might be 8. We don't know, and we have to know. So it's utterly vital. It shouldn't stop any advocacy efforts to make sure that the services reach more than and I think you're probably optimistic with your 1%. We have a problem, and that has to be fought hard. So, Arvin, just thanks for your question about agency, and I want to link it to, I think, a new question from Bianca about like what is a practitioner, what do we do about these big issues like climate change and that. And for me, if I think of agency and I think of the climate breakdown, I immediately think of Greta. So an adolescent girl who sat outside her school and has, you could make an argument, has had one of the single biggest impacts in the last 5 years or so in terms of the spotlight on climate breakdown and all the issues that come with that. So I'd love to have a recipe book to say what you can do, but I think we can never underestimate what our role has the potential to do. And I do think that again, agency of children and adolescents, they are at the forefront and they are speaking up and they're not keeping quiet, and we have to support that in whatever way we can, because as that thing I put up, you know, I'll hopefully die of old age, or maybe I'm already old. But actually our children and adolescents have got a very different future. And so we have to support them. And if they've got agency, they will do it, I think. Thanks, Greg.
Great, thank you very much, Mark. All right, there are a couple of people with their hands up. Ayanda Mtetwa, you've been waiting for a while. Please go ahead and unmute yourself, and then please post your question to the panel. We can't hear you. Kutsu, is there a way of unmuting?
Yes, she's got permission to unmute herself.
Okay, Ayanda, can you unmute yourself? Okay, sorry.
Thank you very much for an informative workshop or webinar. The question I wanted to ask has been covered, so I'll put my head down. Thank you.
Okay, thank you very much, Ayanda. So the next question is from Rumbidza Chitsonga. Please go ahead with your question. Rumbidza, my apologies for the pronunciation. We can't hear you. You just need to unmute yourself.
Okay, it's more a comment. I really liked the idea that was implemented in other African countries where there is like a more systemic approach to mental health care issues. I really like that idea. And if we could implement that in South Africa, I'm sure it will go a long way to reach the young people.
Great, thank you very much for that comment. All right, I think the next person is Elaine. Elaine Koza, you have the floor.
I just want to comment regarding what Mr. Mark Tomlin has stated. It is very, very essential for children and adolescents, whether in their environment, within their working environment, within their environment where they're staying. You know, there are many diseases like HIV and AIDS and other chronic illness that are affecting them as they're in the society. So thank you so much for the information that he has shared, which is broad. Thank you so much.
Great, thank you very much indeed, Elaine. I think that's a really important point, and I really strongly agree with you. You know, I think it's so important when we talk about child and adolescent mental health, not only to focus on the clinical needs of children and adolescents with mental health conditions, but to also address the broader environmental context. So we are just about out of time. I think we have about 2 minutes left, and it's really just down to me now to say a huge thank you to everybody for participating. A big thank you to all the panelists for bringing their wealth of expertise and experience to bear on this really important topic. Thank you for the wonderful participation of everyone online. I think we had over 170 people online at one point. And thank you for all your contributions and your questions. And thank you to the Academy of Science of South Africa for organizing this event. I think for me, there are a couple of really key points that have been highlighted during the course of this presentation. The one is the huge neglect of children and adolescents, even within the field of mental health, which is in itself a neglected priority, and the importance of us urgently uniting as an advocacy movement to advocate for children and adolescents, and also to bring children and adolescents into center stage, to empower and enable them and create spaces for them to advocate for themselves. And I think for me, this applies across a number of different areas. It applies, first of all, to better research and better data. We need the epidemiological data. Of course, we shouldn't stop with other things, but we must get some better nationally representative data. Secondly, it's vital that we expand child and adolescent mental health clinical care. And I think we've seen some really nice examples from rural KwaZulu-Natal and from the Western Cape of how innovative models can be developed to improve access to care for children and adolescents. And then thirdly, it's absolutely vital that those of us working as researchers, practitioners, parents, caregivers involved with children and adolescents, that we advocate for a better world for children and adolescents that will allow them to reach their full potential and to grow into a better future. So thank you so much, everybody, for attending. It's really great to have had you all online. Thanks again to the Academy of Science, and we look forward to the next webinar, which will be advertised shortly. Have a good weekend and take care. Bye-bye.
Thanks, Greg. Take care.